You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 5th, 2025. Our topic today is Jobs, Contracts, and Financial Literacy for the Physician, Part 1. This is presented by Dr. Pandya, an Associate Professor of Pediatrics and is the Medical Director of the Food Allergy Center at Children's Mercy Hospital.
With that being said, I do want to disclose I'm not an expert on this topic. The purpose of this talk is just to assist as you prepare finding a job and looking through contracts, etc. And I think the most important part of this is asking yourself, what are my priorities going forward looking for a job? I know that kind of seems like a redundant, or of course, Dr. Pandya, of course that's what it is, but I think sometimes it's easy to lose sight of this, and then it creates a lot of confusion ultimately when you are looking for jobs as things present themselves. So a couple of questions to kind of center that are, how do you wish to practice medicine, in what kind of setting, as a solo practitioner, in a multi-specialty group, etc.? What kind of compensation are you expecting? What level of compensation are you expecting? How do you view working in a managed care environment? What type of setting do you prefer to practice in? Where do you prefer to live ultimately? What kind of school system may be important for you to know about? And amongst those things, if I take all those things together, what are my 1, 2, and 3 priorities? Because certain jobs may have some of these things, but they may not have other parts of these things. So maybe ranking in terms of individually, what is the most important for me? Is it geography, or is it the financial compensation, or is it the quality of the environment? Because all of those things may lend a different answer in your search. Other questions to consider is, what kind of patient mix do you prefer to see? What does call look like as you go forward, in the practice? How many days of call are you willing to take? And is the practice having you, take? And then, are there job opportunities for your significant other? Bottom line is that answering these questions can give you a sense of what your priorities are, and when you are looking at different practices, what to prioritize kind of going forward in your search. The preparation process as a second year starts now. So it's always good to start early. Everyone is different. Actually, some fellows are starting at the end of their first year in terms of the prep process. And so you may ask, well, what should I be doing in that preparation process? Having an updated CV is very important, because as you look for jobs, even if you do a call out to a private practice, let's say, and they are saying, yeah, we're taking on people, send over your CV and cover letter. You don't want to have a delay in those things that, when they're asking for them. So keeping that updated, writing a cover letter, more to come on this, having some letters of recommendation ready to go. Not all practices are going to ask for a letter of recommendation. I will say, in my experience, academic practices are for sure going to be asking for letters of recommendation. And then some certain private practices may be asking for those as well. So it's always good to kind of be over-prepared with that, and asking your faculty, are you willing to write a strong letter of recommendation in support of a future job, is an important question to ask. Also, in terms of the letter of recommendation, there's 2 ways to approach that. Let's say you're really interested in staying on at a X, Y, and Z academic center. You could have a tailored letter of recommendation for that practice, or you could have kind of more of a generic letter of recommendation if you're applying for, let's say, multiple private practices. So those are some things you can do early on to prepare. How do you look for jobs? So word of mouth, I would say, is ultimately the best way, because you get kind of real live updates in terms of, well, this is what's available, this is realistically which practices is taking on what, etc. And then in terms of the college and quad, they have career centers, websites. They also have job fairs at both of their conferences. So and then that's kind of what's written here too, networking events. But in addition to that, having just the job fair that you go to. Recruiters are something you can, of course, reach out to. In allergy immunology, of course, we're a smaller field, so there could be utilization of this, but more of it could be through these as well. And then if you're especially geographically oriented to a specific area, just cold calling practices that you know about certainly is important, certainly could be something to do. And then for academic opportunities, specifically, the program director will receive a list kind of on like a monthly or every other month basis of practices that are looking for a job or academic places that are looking for a job. So ask your program director to send those over to you if you haven't received that already. How do you make yourself marketable? So if you're going into academics, think about what you can advertise yourself in terms of offering the university: research, administrative experience, leadership. So both for academics and for private practice, one thing that you can also use to make yourself marketable is the kind of patients you encountered during your training. Um, if research, so we think of research traditionally in the academic sector. However, some private practices are performing clinical trials heavily. So if you've had experience with that, or if you kind of know about that, making sure you market that as well. Joining committees during your fellowship is also important. Again, it helps connect you and helps just make you look more robust when you're preparing for that process. If you're tech savvy, like particularly now, we're in an an era where we're using a lot of digital dictation systems. So let's say you're have experience with that. That's something you can talk about in your interview process. If you have any computer aid instruction or image analysis or medical record or computerized medical record experience, you can talk about that as well. Acquiring broad work experience. So let's say you are interested in private practice and you're at a university center. If there's opportunities to do private practice rotations, I would certainly be inclined to take a look at that. Medical Spanish, particularly if you know you're interviewing at an area where there's a heavy Spanish speaking population, having that as a skill can certainly make you more marketable. Understanding the job hunting process itself and how to present yourself. Employers are going to pick up on if you know the terminology or not. Understanding what's driving the employer search, market trends in the area, and how an employment offer would be a good match in terms of mutual expectations. And then clearly communicating why the position you are interviewing for is a good long-term career move. And so, of course, this point number 6 is a little bit counterintuitive to the whole first part of what I talked about, which is knowing priorities, but maybe being a little bit flexible in your expectations. And also part of being flexible in your expectations is ranking those priorities in terms of what's most important and what maybe could be less important on that scale. So, resume versus CV. Resume is typically a shorter version of a CV. It has your medical, education, major accomplishments, a little bit of bio, that type of thing. A CV is typically longer than a resume. It has all of the academic and professional accomplishments listed in detail. However, generally when we're preparing, so resume is going to be maybe 1 to 2 pages. A CV, we're going to limit to about 3 to 4 pages. All good CVs, regardless of how robust you are, typically they're not longer than 5 pages, I would say. A cover letter is essentially you telling a future potential employer why you're interested in the position and what you have to offer. We want to try to limit this at 1 page maximum. Similarly to the letter of recommendation, you can have a cover letter specific for a position if you're really interested in that particular position, where you call that employer out by name in the cover letter. Just make sure you kind of like look at that thoroughly and have that kind of aligned with your other cover letters, etc. Letters of recommendation. So how many should you get? 1 to 2 is generally sufficient. I would say maybe 1 on the end of private practice, 2 for most academic practices. I would say it's rare that you need more than that, but at least calling out for 2 maybe at the beginning. And then if possible, it is professional courtesy to give your letter writer a 3-week notice, but also make sure they're aware of their deadline. And then it's also considered good form to give them a thank you card, as well as a personal reminder in terms of where the letter should be sent when they are needed. And then you want to make sure you're getting a strong letter of recommendation. So I would, look at the evaluations you've gotten and who's giving you the strongest comments in terms of your performance. And then if it's still kind of hard to tell based off of that, you can just ask, of course, hey, do you think you can write a supportive letter of recommendation or a strong letter of recommendation? Also, if someone tells you, I'm not able to write a strong letter of recommendation, it's not speaking to any limitations of you as an individual. It's just that that person may not want to limit your opportunities in terms of, where you're going forward if they don't feel like they can write you a strong letter of recommendation. So all of those things are things to think about. Before you interview, especially if you're traveling for an interview, it's kind of nice to set up a phone interview to get a basic understanding of what kind of position you're interviewing for, as well as expectations. It can help save you the cost of traveling to the place. Look over the website, see kind of what the practice or the university system kind of looks like, so you have some familiarity before you go for an in-person interview. Additional deciding factors, so we've talked quite a bit about this, but again, kind of prioritizing which of these falls as number 1, 2, and 3, and which of these can go a little bit lower on the list. So types of practices that are available for hiring include academic practices, of course. Most of these are university housed practices, similar to, the one that we are talking from this morning, Children's Mercy. So one thing I want to say is that sometimes you can have an academic practice at a hospital that is associated with university. So that's very similar to what we have here. So Children's Mercy is a freestanding children's hospital that is associated with a University of Missouri, Kansas City. So kind of get an idea of what that affiliation kind of looks like between the practice that you're at as well as the university side. There's also health system model based practices. These are kind of diminishing, but you're essentially employed by a health system. So all of your benefits will go through the health system. However, you may function more closely to a private practice. And so asking a little bit about, what it looks like working for that bigger health system, any specific requirements or asks of the health system to you as an individual within that practice are important to know. There's, of course, private practice, and there's a couple of ways you can be in private practice. You can be in a hospital employment or a multi-specialty group. You can be in a physician-owned practice or a private equity-owned practice. All of these have different requirements. They have different potentials in terms of salary. They have different potentials in terms of how they ramp up your schedule, how many patients you have to see. So all of those things are things you want to ask either whoever's interviewing you or individuals who are working within the practice. Locum tenens is available for allergy. So this is essentially where, you go and work at, like you're part of a locum tenens company that will, contract you to a hospital for like a week or a month, or a practice for a week or a month, etc. I will say the opportunities for locums in allergy are exceedingly rare, and most of the jobs are going to fall within these 3 domains. Salary. How can you make money as an allergist immunologist? So salary is, of course, the big way. Things you want to maybe ask about: is it fixed? Is there a conversion to production model? Is there a production model from the get-go? Those are things you kind of want to have an idea about. What is the signing bonus? Is there an opportunity for a signing bonus? Relocation allowance, and then loan repayment. This is especially important for many of us who are under PSLF, and whoever's in that program knows all the issues that are within the program. And so if there's even a doubt in your mind about continuing being in the program, and if you want to convert to a refinancing process, it would be really important to know if a practice is willing to align with that and help pay off some of your loans. The majority of loan repayment is going to happen, I would say, again, anecdotally or based on my experience, more in rural areas. So again, priorities, right? Everybody's priorities are different. So just know what yours are in terms of this. And then, of course, additional expenses that can come up are license expenses, DEA, board reimbursement, stipends. And then knowing if your practice is RVU or salary based. A lot of people, when they start their jobs, especially in private practice, they start as a salary-based practice. So you kind of have like a fixed salary for a year, versus RVU. So RVU based is like what you're seeing and how much money you're making from the individual patient encounters. And if you are looking at an RVU based, how does that RVU play into your salary? Do your RVUs get put into the practice and then they kind of split that? Or is your individual performance through your RVUs coming directly back at you? Those are some things to know. Additionally, with the RVU question, are those based on AAMC reimbursement standards or compensation standards, or are they based on MGMA? AAMC we're largely going to see for peds only practices, and MGMA is going to be more where there's more adult practices. So kind of know that information. Do they own an infusion center? Do you get part of the money that comes from the infusion center? That's additional questions you can ask. Just know in a private practice setting, as the first year employee, you're often going to be losing money to the practice. So this is kind of a investment that they're putting in you as you build up your patient base. So kind of knowing what that means in terms of how many news follow-ups you'll see, having a clear knowledge of when do they plan on paying you and how frequently are they going to pay you. I know, again, this seems like, oh, shouldn't it be standard for all practices? Isn't there a standard thing that every practice has? And actually the answer to that is no. And so you kind of do want to clarify that as well. And then when are you eligible for a raise and what parameters are assessed based on raise and bonus? Even if you are at an academic practice, ask this question. Important to know. And then your salary is, of course, determined based on market value. This is going to be different depending on location, practice type. With a couple of our second years, I recently pointed them to the college website that had a great article on provider compensation. So this is 2021, but we actually have a 2024, 2025 article. MGMA, of course, updates their data. AAMC, of course, updates their data regularly too. In terms of revenue, what is the overhead to revenue ratio? So overhead is what the costs are needed to maintain the practice, like the office space, the rent, the light bill, the supplies, the materials that you're paying for basically in the practice. And then the revenue is what you're bringing into the practice. So what is the percentage of overhead to ratio? Typically it's going to be about 40 to 60%. So if there's a practice that's saying it's higher than 60%, ask where those expenses are coming from. Like what additional things are they paying for that you should know about? Sometimes, just for you all to know, to offset this ratio, practices may offer additional services that are outside allergy immunology. For instance, there are a couple practices I knew that I interviewed at that offered like Botox injections in addition to like allergy immunology work. So then knowing what your expectations are you expected to do that work? Are you going to get paid for that work coming into the practice? Is that just purely to offset the overhead costs? And then if that is something you want to do, is there appropriate training that you can get to, be able to do that? So all of those things are important to know. What is the payer mix? What types of insurances? Are there any excluded? Medicaid, Medicare, HMOs, self-pay? Benefits. You want to know about benefits for your job. What are the medical benefits, dental, vision? What's the retirement package? What is tail coverage? So tail coverage is, and we have a little bit of this that comes in a later slide here, but what is the coverage in terms of malpractice when you leave the practice? Most universities provide this. Private practice is going to be very variable in terms of what and how they provide, so you want to clarify that. Disability, short and long-term disability. So if you are looking into getting disability insurance, and who should be looking into disability insurance, this answer is different depending on every single individual and every single family, potentially. So there's two types. There's going to be short and long-term disability insurance. If you are the primary breadwinner in the family, and let's say something happens, either, pregnancy happens, or if you are in some type of accident where you can't be, let's say, physically in clinic and you have to do like telehealth all the time, the disability insurance kind of provides some degree of guaranteed matching of salary, maybe not at your full 100% in terms of what you used to make, but up to a certain amount. 60%, for instance, would be like a standard number. So there is language within disability insurance that you want to look at. Own occupation short-term disability insurance is important in terms of that compensation. So look into if the practice is offering that, and if they're not, do you want to obtain that in your training before you go on? So why would you want to do that? Because the rates as a trainee are exponentially lower than they are if you are to try to get that once you graduate. And a lot of people kick themselves for not getting that sooner rather than later. Also, some residencies may have already put you into a plan, so kind of clarify if that is something that has already been done, etc. CME expenses, dictation, up-to-date. Up-to-date is really expensive. Most practices do not pay for this, so it's a luxury that most of us have at academic centers. Is there interpreter services? Are they paying for memberships like the college, Quad AI, and then payment for specialty boards like internal medicine or PEDS? What does the partnership track look like for private practices? Is it partial? Is it full? Is it based on number of years that you've worked? Is it based on performances? Is there a buy-in process? What about the buyout process for the partners from when they're retiring? Are they completely buying out of the practice, or are they partly buying out of the practice where, let's say, allergy shot revenue is still coming to them even when the remaining revenue, let's say from like seeing patients, is going to you? All important things to know. Private equity. So there are private equity firms throughout the United States that will take acquisition of private practices. In the previous model in the United States, most private practices were primarily physician-owned or privately owned. Private equity firms are basically practices that have been sold to the firm. And so salary, the number of patients you see, the number of clinics you do, it's all dictated based on the private equity firm. So there is benefit here in terms of potentially the marketing needs and getting your templates full. That could potentially be done through the firm. However, in terms of compensation, number of patients you see, number of clinics, you may have less autonomy on that. And so you should ask, who owns the practice, and then expectations within that private equity firm. And then also, because they're setting up your templates, what kind of patients are you seeing? Are you seeing only like mast cell disease concerns all day, or are you seeing a mix of, all different types of allergic immunologic diseases? Something you want to clarify when you're in your job hunt. If you are looking into an academic practice, there's 4 levels of university appointments that you can have: clinical instructor, assistant professor, associate professor, and then clinical professor. Clinical instructor is the lowest level that you can have at a university appointment. It does denote a lower pay amount, and it could denote a lower level of potentially having say in certain decisions that are made into the practice or into the university. Most institutions wait 5 years before you can promote to any of these levels, so 5 years out of graduation. So then you can promote to assistant professor. The majority of practices out there are offering assistant professor level in terms of where they're hiring. So if they're offering an instructor level, maybe inquire why they're kind of looking at the instructor level as opposed to the assistant professor level. And then, of course, there you can promote to associate professor, professor. Again, if you're very interested in a robust academic job, maybe understanding what that promotion process looks like. Do you have help with this? Are you doing it all on your own? And then another thing here to look for in a university appointment. So I put all clinical here, but you don't have to have this marker denoting clinical instructor, clinical. It could just be assistant professor of pediatrics, associate professor of pediatrics. For instance, my university appointment is currently associate professor of pediatrics. So these markers here kind of denote sometimes what track you are looking into. Is it a purely clinical track? Is it an education track? Is it a research track? Is it a mix? And if it's a mix, what percentage of time is devoted to each of those things? Those are all things to clarify. CME, of course, we know that we have to maintain CME as physicians, both at the licensure level as well as your, board level. Like the ABAI requires a certain amount of CME that's completed, and then your employer may require a certain amount of CME as well. So, are there allotted CME days? Are there funds available? And what are the credits that are required within your state? What is the documentation process that is required? If it's like, let's say, at a university level or if it's at a private practice level. And just know that anyone can undergo a CME audit at any place. So if there's not a requirement in terms of where you keep that, I would make sure that you're kind of having your own way that you keep all of that, so that if you do ever, hopefully none of us ever undergo an audit, but if you do, you're kind of prepared to give them the right documentation. Okay, malpractice insurance. So malpractice insurance is a specific professional liability insurance that covers you in the case of a patient's injury or death or a bad outcome. This is usually available through traditional insurance carriers or from medical risk retention. So, kind of knowing which of these your practice offers. And there's two types of malpractice insurance. There's claims made or occurrence insurance. So, claims made provides coverage if the policy is in effect when both the incident took place as well as when the lawsuit was filed. Some claims made policies are written to provide a period of coverage referred to as the tail that extends the coverage after the policy ends. And the cost of tail coverage may be covered by your previous practice to ensure adequate protection to the practice. So asking about, well, do you offer tail coverage? If you do, for how long? Is there a cap on the amount that you offer? Is something to know when you're looking for jobs. Also, there's occurrence-based insurance, which covers any claim for any event that took time during the period of coverage, even if the claim was filed after the policy lapsed. Again, similar things to ask about. And then also, is this being paid for through your practice, or are you going to have to pay this out of pocket? Additional things to ask about. All right, restrictive covenant. So this is often referred to as a non-compete. I'll tell you what it is first and then kind of tell you where we're at nationally in terms of this. So this is an agreement between an employer and an employee that limits the employee's ability to compete after leaving the employer. Meaning, if you left a practice, in what radius are you not allowed to practice in? Is there a certain patient demographic you're not allowed to see? On a national level, they have essentially talked about making restrictive covenants or non-competes like not legal, basically illegal. And that's true for the majority of other jobs out there. However, in medicine and law, those are not as black and white. And so there is still, I would say, some value to looking at the language in your contract with this until we know for sure that non-competes can never be enforceable going forward in the future. I would protect yourself is what I'm basically trying to say here. So important things to consider that are whether the employment can proceed without violating the provision, whether the provision is enforceable, and the likelihood that a former employee will take action if there is a breach. So what am I saying here? What I'm saying is if you do leave a practice and if you go practice, in an area that is said not to compete, what does this look like essentially? And the contract for restrictive covenant will list how far from the clinic or from the practice you are not supposed to be practicing in. However, one thing to know is that let's again take Children's Mercy as an example. So Children's Mercy, we think of the main hospital, right? But then we have a hospital in Kansas also. So on I would say 20 minutes or about 15 miles from the main hospital. And then we have multiple satellite clinics that are covering the Kansas City area and even outside of the Kansas City area, some that are in rural areas of Kansas and Missouri. So the language in your contract may say that the restrictive covenant applies to all sites, part of the practice. So that means, let's say you have like a 5-mile coverage or restriction from the practice. So it's not just 5 miles from the main hospital, it's 5 miles from any satellite site. So that covers a bigger area that you're restricted from practicing in. There's also time period limits. There can be a 6-month, 3-month, 1 year, and then there could be a type of patient restriction like pediatric only or adult only, or just allergy immunology patients. So I would discuss this with an attorney. Like I said, there is legislation that's making these non-enforceable. However, the medical realm and the legal realm, like being a lawyer or being a physician, is where a lot of these things, I would still recommend just protecting yourself and knowing that you are protected when you're looking for a job. All right, in terms of your schedule, is it flexible, fixed? What's your admin time? Is there Saturday, Sunday coverage? If there is Saturday, Sunday coverage, how does that go into funding the practice? Is there inpatient services? What does call look like? What do vacation days look like? Some practices may say, well, we don't have set vacation days. And that is true. Some practices may not have set vacation days. Basically, they're just expecting you to make a certain amount of revenue for the practice. And, the vacation days you can take at any time whenever. However, they are hoping that it doesn't interfere with the revenue process. So the vacation may tie into what are the expectations for the revenue. Is there in-house lab imaging? If there is in-house lab and if there is in-house imaging, who is reading the imaging? Like if you're ordering a chest x-ray, is there a radiology fee that you have to pay? So some practices, there is no radiology fee that they want, and so they are reading their own x-rays. So do you feel comfortable taking on the liability of reading an image if you're ordering it? It's something for you to decide on a personal level and for you to clarify with the employer. Allergy shots and infusions and testing, knowing who is doing the skin testing, knowing who is doing the allergy shots, who's mixing the allergy shots. Are you doing standard pre-made mixes? So this came up in the immunotherapy talk that we did. Or are they custom based on skin testing? Are patients placed on shots with negative skin test? If they are they performing nasal challenges? Nasal challenges do have utility in determining whether a patient has allergic rhinitis, but kind of knowing that is important. Who is doing the mixing? So, most practices in the United States are doing their own mixing. So is this done at the physician level, mid-level, nursing level? And then what time do you have allotted if you are expected to do the mixing? Who's administering the shots? Does the practice allow immunotherapy, specifically I'm talking about SCIT here, subcutaneous, to be done at home? In addition to allergy shots in this realm here, beyond subcutaneous, are there other modalities of immunotherapy, like intralymphatic immunotherapy that are being done? Is there SLIT being done with FDA approved products, or are you mixing the SLIT based on extracts that your practice is purchasing? Knowing the answers to all of those. Immunoglobulin infusions, did the practice do IV only or sub-Q, or do they do a mix? Do you have privileges with an infusion center? Being in a PEDS-only institution, we do a lot of sub-Q. However, a lot of adult-only areas, adults don't want to do sub-Q and would prefer doing an IV, infusion once a month, which is fine. But do you have the right setup for this? Who assists with orders and lab follow-ups? Do you have dedicated nursing support or support staff for getting biologics approved if there are denials? For food allergy, are you performing food challenges? Are you performing OIT? What are the protocols for OIT, being carried out? Who is managing these reactions? Is there sublingual food immunotherapy that's being done? If so, what are they using to mix the sublingual immunotherapy? How are they making that? Are you expected to make that? Is the nurse making that? All of those things are important to know. What does the staff demographic look like in terms of additional allergists? Are rotators coming through the practice? What's the nurse ratio to physician ratio? What's the adult to peds ratio? Who's the office manager? Who's managing the billing? Are there MAs? Who's doing check-in? Can clinic staff put in orders for you? Can they start notes for you as well? Who's doing prior auths? Is there any anticipated staff or turnover? Has there been so in the last couple of years? If so, then why? And who is seeing same-day patients? Especially for private practices, they often offer same-day patients to be evaluated. So, with regards to billing, who's doing that? And also if someone else is taking care of it, what is your access to looking at the numbers? What is the access to measuring productivity, performance? If you're not RVU based, how are they calculating productivity? Who's reviewing the billing? Are there house staff meetings to review that information? Is there an EMR system, Epic, Cerner, or is there no EMR system? And is it a paper-based system? Most practices are, of course, utilize electronic medical records. That's kind of required. And if there's a practice that's paper-based, they're probably paying a fee, like a penalty fee, to continue being paper-based. If so, what does that look like in terms of is that being taken out of your salary, etc.? Is there a dictation system? Is there a scribe? Is there a different EMR for prescription versus notes? And is there any technology for documentation, like I talked about? Are there any conferences, journal clubs? Is there a culture of discussing difficult cases? Visas are, of course, an important thing to know, and this has been a hot button topic as of this year as well. So there was a pause on J1 visas that was lifted on June 18th of this year. H1B was suspended for work visas in early 2025, and the EB2, employment-based green card category is currently suspended until October 1st. While I'm not the expert on this topic, just knowing what your practice is like in terms of supporting the visa process is important to know. Consulting for pharmaceuticals can be done as either an adjunct to your primary job, or you can specifically go into that. If so, there's going to be additional questions in terms of your qualifications to be able to consult. Now, I want to say that this is different than being like a speaker for a company, or it's different than doing, let's say, a virtual, or not just a virtual, but doing like an advisory board. So, yeah, important to know all of that. Contract review, again, we talked about most of these things. I think one of the other thing is the termination rules, both from your end as well as the employer's end. How far of a notice do you have to give? Are there any capitation payments that you have to take into consideration? So who should review your contract? It can be a lawyer, it can be the program director, or it can be a faculty that fits your style. Not everyone utilizes law services to review contract, but of course, understandably, the majority of us, when we graduate our fellowship, knowing that we're not familiar with a lot of these languages, we do often rely on those services to look at our contracts. So one really important thing, actually not one really important thing, if you took nothing else away from today except this slide, this I would say is the most important slide to take away with regards to contract review. You should know what parts of the contract can be changed and what cannot be changed. A lot of academic institutions and health system-based practices have a boilerplate contract where the language of the contract cannot be changed. And so in terms of what can be negotiated, this comes from the offer letter. So the minute you sign something, the negotiation is done, basically. So knowing that sometimes the contract itself cannot be changed, but the offer letter can, is an important principle going into this process, so that you know where modifications can be made. Also, if something doesn't exist in the contract, it doesn't exist. So just an email or word of mouth saying, oh, for sure, we'll give you like 2 half admin days for research, that's not enough until it's written into the contract, including things like salary or bonus payments, etc. Negotiation. I would say that the majority of new faculty are afraid to ask for more by fear of the employer, potentially revoking the contract or something like that. And what we have to say is just, there's no harm in asking. The worst that can happen is that they say no. And they may say no. They may say no to some things. They may say yes to some things. Work on those negotiation skills by knowing what you're prioritizing, putting things in writing, how to have discussions on things you prioritize, such as salary, and tailor your requests based on the average of the region in terms of salary specifically. Other considerations, I think we talked a lot about the referral base, but where the referrals are coming from, like other specialties versus primary care. Are you supervising an NP? Do you have help filling out the paperwork with regards to that? Is there standard hours in your work schedule that are needing to be adhered? What's the albuterol and prednisone policy as well as the refill for these? What is the parental leave policy? Is there a parental leave policy? And then do you have disability insurance or reimbursement for that? And the reason I say that, and I think I had a discussion recently with a couple of our fellows about this. So federally, the protection that you have going into parental leave is that you will still have a job at the end of the day. The parental leave policy from the United States does not require that you're paid during that time period. So that actually comes from your employer, as well as potentially adjuncts like family leave or family pay or bonding pay that you may get. And so know what that is if that is something you're considering for your future. And then also before you begin, have some smart phrases ready, have some templates ready, adapt a style, be systematic, contact information for your mentors, network with other providers, be comfortable with procedures that are performing, request the day off for boards as well as before. Try to have that not be a vacation day. You could potentially work with a financial advisor, but I will defer all financial questions to Dr. Barnhouse, who will be a great resource for that. And with that, that's the end of my portion here.